my name is Amina Malik, and I'm an associate professor of ophthalmology at Weill Cornell Medical College and the director of oculoplastic surgery here at Houston Methodist Hospital. And it's my pleasure this morning to be speaking with you all about eyelid lesions 101. We want to cover all the basic eyelid lesions that you're going to see most commonly in your day-to-day practice and give you the knowledge that you need to help differentiate which of these are benign and can be observed and your patients reassured versus the ones that are malignant and are going to need more attention. So let's dive right in. I want to start with just a basic review of your eyelid anatomy. So we know that the eyelid is the thinnest skin in the body. And if we go back to our anatomy days, we know the outer layer of the skin is the epidermis. And on top of that, we have our melanocytes. Deeper to the epidermis, we're going to have the dermis. And what lives in the dermis? Well, we have the hair follicles, we have the sweat glands, as well as the sebaceous glands. So when we talk about eyelid lesions, we can have lesions that arise from all of the levels of the eyelid skin, including from the melanocytes, from the epidermis, and the dermis. And there are going to be benign and malignant lesions that arise from each of this. So starting with the epidermis, the benign lesions we're going to see are going to be the seborrheic keratosis, often abbreviated as SebK, as well as acrocordon or skin tags. And we're going to delve into these a little bit more in detail. But we also can see malignant lesions that come from the epidermis. And these are the ones we, of course, want to recognize when we see them in office so that we're not missing malignancy, which can lead to more serious problems for our patients. And these are going to include basal cell cancer, squamous cell cancer, as well as keratoacanthomas. Now, when it comes to the dermis, we can also have benign lesions and malignant lesions, and we're going to delve into that a little bit later, but let's go ahead and get started with the epidermal lesions. So, one of the most common eyelid lesions you're going to see in your practice is an imaged here, which is going to be your seborrheic keratosis. So what do we notice about these lesions? They often have a greasy, stuck-on appearance. They can often be brownish in color. And these can be observed if your patients are asymptomatic, but if they are bothered by it, they're very easy to shave off with an excision biopsy as well. And what you notice here is, again, they're kind of that greasy, oily appearance, and that's going to want to clue you off to the seborrheic keratosis. In addition, we often can see acrocordon, which are imaged here, and these are also known as your basic skin tags. Now, skin tags, we know, can develop in any area where there's a lot of skin friction. So your eyelid, we're blinking a lot, your underarms, different places in our body or the neck as well, where there is a lot of friction. And so what we can see here is that they kind of often will have a pedunculated lesion, a pedunculated base, and these can be very easily excised in the office as well. Now, those are the two most common benign epidermal lesions, but what we really want to talk about is going to be our malignant ones. So, what are the features that you want to be thinking about when you're examining your patient and looking at these growths? What things are going to trigger you that this could be a skin cancer? Well, number one, if it's ulcerated. Skin cancers, we know, outgrow the normal pace of the surrounding skin, and so you often will see an ulceration or central divot. Number two, madarosis, or loss of eyelashes. We know skin cancers are destructive, so it's going to destroy your natural lid anatomy, so you're not going to see the normal contour, and the lash loss is a tip-off that this could be something malignant. Also, these are often asymmetric because they are irregular growths. So when you see a lesion that's not perfectly round or smooth, you also want to be thinking, could this be a malignancy? In addition, anytime we see lesions that have a lot of telangiectasias, which we know are fine blood vessels coursing across the course of it, that's also suggestive of a potential underlying malignancy and might need to be biopsied. So these are some 4 hallmark symptoms you want to be thinking about when we're evaluating our patients to see if their lesion could represent an underlying malignancy. Now, aside from these signs, there are also important history questions to keep in mind. Do they have a history of previous skin cancer? We know that if a patient has had one skin cancer, they are at higher risk for development of others. In general, any type of skin cancer, you definitely have a higher risk. In addition, did these patients have a lot of sun exposure in their younger years where they could have that UV damage, which we know is a risk factor? Also, do these patients have fair skin, blue eyes? Those patients are also going to be at risk for skin cancer. So just things that we want to be thinking about when we first meet our patients and their history, as well as important things to be examining when we see them. So let's see some actual photographs of some of these eyelid malignancies. So basal cell carcinoma is seen in all three of these images. This is the most common eyelid skin cancer, accounting for 90% of them. And so it's very important that you want to be familiar with the features of this cancer. Oftentimes, it's a pearly white lesion, most commonly seen on the lower eyelid, but can also be seen in the medial canthal area. We can see here that central ulceration. That is a definite hallmark sign of basal cell cancer. This is the more rodent ulcer characteristic of basal cell carcinoma, where you can see the ulceration centrally. Also here you can see there's telangiectatic vessels and the loss of the lashes, the madarosis. So all signs, again, that are classic for basal cell. These patients also have fairer skin. We see the blue eyes, again, pointing towards the diagnosis of malignancy. Now, less commonly seen, but also very important to think about when we are discussing epidermal malignancies is going to be squamous cell carcinoma. And these are less common, about 5 to 10% of the epidermal lesions. And what we see often in these, in contrast to the pearly white basal cell, is a red scaly lesion. Sometimes they'll have a precursor of an actinic keratosis, which is a scaly lesion that can fall off and crust over, but then they will still have this persistent lesion. And these can be more invasive. They can have perineural spread, where they can travel along the cranial nerves and lead to cranial neuropathies, including double vision. So it's really important to not want to miss the squamous cell when we are evaluating these patients. So we've covered a lot of epidermal lesions. We have our benign ones, again, including seborrheic keratosis and acrocordons. And then importantly, the malignant epidermal lesions, most commonly basal cell carcinoma, as well as squamous cell carcinoma. But let's now shift gears to talk about the dermal, the most common dermal growths on the eyelid. And so we're gonna have the benign ones. These will include the chalazion, which I'm sure many of you are already familiar with because they are so common. Epidermal inclusion cysts. A subset of that is going to include the milia. And then we're going to be discussing hydrocystomas. And then there are also malignant lesions that arise from the dermis. And importantly, you don't want to miss this either, sebaceous cell carcinoma. And we'll show you a description of that here shortly. So these are the most common benign dermal lesions that you're going to encounter in practice. Let's dive into what those look like. So chalazion. So let's take a minute and just review your eyelid anatomy. So if this is a cross section, we know this is going to be the posterior tarsal plate. This is your eyelash. This is your skin, and this is the orbicularis muscle in here, okay? So when we talk about the glands of your eyelid, we have the glands of Zeiss and Moll, our sebaceous glands, and then we have the meibomian gland, which live in the tarsus. And so when we talk about chalazion, well, what is it? Chalazion is essentially a blocked oil gland of the eyelid. And this can be internal if it's affecting the meibomian gland, or it can be external when they're affecting the sweat glands along the base of the lashes. So pictured here, we have an external chalazion, which is a very classic appearance. When they're acute, they can be tender and red and swollen. When they're, sometimes will come to a head and be ready to drain, where we can see a little scab. Or they can be internal, where they're affecting the meibomian gland here. And in either of these cases, these can be often managed conservatively with warm compresses. The heat can melt the oil that is clogged in there, and we often supplement it with medication. Doxycycline is often used because it can both melt oil and treat any potential bacterial infection, most commonly seen with staph. If it does not respond to medical therapy, sometimes we can offer incision and drainage for these lesions. So chalazion, something very commonly seen. It is Greek, so it is pronounced chalazion, not chalazion, though many people do call it that. So just important to know what these are, but important to remember, again, the signs of the malignancy, because sometimes these can masquerade as a malignancy, especially if you see one that's not healing or not resolving. Always want to keep the skin cancer in the back of the mind. And so what do we have here? Another benign dermal lesion, the epidermal inclusion cyst. These are very commonly seen where keratin gets trapped under the skin surface. You can see kind of the whitish keratin under there. And a subset of that is going to be the milia, which are very small, fine, whitish lesions that are smooth in appearance, and these can easily be treated either by unroofing them with a needle or surgical excision. But in a case like this, we would want to do that in sort of a staggered approach to avoid too much skin loss at one time. Next here, we have the xanthelasma, which is another very commonly seen dermal benign lesion. And what's the key feature of xanthelasma? Well, xanthelasma is cholesterol that is trapped in the dermal layer. And so what we see is a yellow appearance to the skin due to the underlying cholesterol. And it's most commonly seen in the medial part of either the upper eyelid or the lower eyelid. And you can see in this patient, it's really visible in all 4 areas. And up to half of these patients can have elevated cholesterol in their blood, so they definitely need to have their lipid panel checked if that's not been done, so they can get that under control. These also are benign, so they can be observed, or if they are bothersome to patients, can be treated with either laser or direct surgical excision. Okay, so we just talked about a lot of the benign dermal lesions, but what we always want to keep in the back of our mind and never miss, of course, is the malignant dermal lesion, which is the sebaceous cell carcinoma. And this is actually known as the great masquerader. In my career, I have seen multiple patients who were being treated for chronic blepharitis, when indeed it was an underlying sebaceous cell carcinoma. So what are sort of the hallmark features of this? The history is going to be that of, oh, I've had a sty or blepharitis for years and it's just not going away, because it really can look like those lesions. They often have the yellowish appearance of a chalazion, and oftentimes they'll have a reddish inflammation of the eyelid. You might think this is just a chronic blepharoconjunctivitis, when in reality, this patient was not responding to typical conservative therapy, and so a biopsy is indicated in that situation, and it showed the diagnosis of sebaceous cell carcinoma. And this is also an important one to be familiar with, because it can have skip lesions where in one area the eyelid looks totally normal, and in the area next to it, it has the sebaceous cell carcinoma. So when we talk about biopsy, it's also important to biopsy many different spots on the conjunctiva to avoid missing the true diagnosis. And this is one of the cancers that can spread and have lymph node involvement, and can be associated even with mortality. So we want to make sure we do not miss this diagnosis when we are evaluating our patients who are presenting with eyelid lesions. So we've talked about the benign and malignant epidermal and dermal lesions, a lot of information, but we don't want to forget the melanocytic lesions of the eyelid, as these are also commonly encountered. And so when it comes to melanocytic lesions on the eyelid, I think it's important to realize that we have benign nevi, and these can be pigmented or non-pigmented. So just because we see a pigmented lesion on the eyelid, it does not necessarily mean that that is going to be a cancer or a melanoma, as we often can see benign nevi on the lid that have pigment. But we definitely do not want to miss the diagnosis of a melanoma on the eyelid. And so let's talk about some of the features distinguishing the benign versus malignant pigmented lesions. So when it comes to nevi of the eyelid, as imaged here, what are we seeing? Well, the lashes are growing through it, which is a really important feature. When any eyelid nevus should have lashes through it. If those are missing, that could be a sign that it is something malignant. In addition, history is going to be crucial here, where patients often have had these for years and they're not changing and they're not growing. So a lot of times those can be observed, but anytime we're seeing growth of these lesions, that's going to be a sign to biopsy. Or if there is a loss of lashes. Lash loss, okay? So those are important things. Now this is pictured here. This is a congenital kissing nevi, which is rare, but can be seen. And sometimes these can undergo malignant transformation. So it's important for these to be observed over time, even if you believe strongly that your patient has what looks like a nevus. I will follow them once a year just to ensure that there's no clinical growth, and they should also be educated that if they notice a change, to come back to consider the biopsy. And the nevi of the eyelid can also be non-pigmented, which is important to realize. The one we saw had the classic round appearance, but they can be white, not have any pigment at all, but they'll have that smooth surface, can have hairs growing through it, and that classic history of it having been there for years and not changing. Now, in contrast here, we can see two examples of eyelid melanoma. So what are we noticing in these pictures compared to the last one? Well, definitely the variety of the brown pigment. It's not a homogeneous color. So anytime we see variations in the degree of pigment or brown, that is a sign that it could be a malignancy. In addition, you can kind of see just this irregular growth and spread. It doesn't have well-defined borders as you would see with a nevus, but rather just kind of that spreading appearance. And you can see all of the lashes are missing in this central area. So this is definitely something that would need to be biopsied with high concern of melanoma. Likewise here, we can see the really dark brown pigment. That also can be a sign of a malignancy. And you can see the surrounding erythema and destruction of the lid margin. So just some of the common things that you want to be aware of when differentiating benign versus malignant pigmented lesions of the eyelid. So I think we've covered a lot of material in this short period of time, but I'm hopeful that what we will take away is the signs of malignancy of the eyelid, as that's really what we don't want to miss as clinicians. So we're going to be paying attention to the presence of ulceration, the madarosis, the loss of lashes, the telangiectatic blood vessels, a lot of fine blood vessel growth on it, when there are irregular borders and asymmetry to the lesions. And these are all the things on the signs that we want to look for in exam. But then on the history, we always want to know, is it growing or changing? Any history of previous skin cancers? And a history of sun exposure in their younger years, because those are all going to be risk factors. So I'm hopeful that after this talk, you'll be more familiar with the most common eyelid lesions when we are seeing these in our office, to help be able to guide our patients when these can be observed versus biopsied. Thank you so much for your time and attention.